right, thank you very much, and thanks for inviting me. So I've been told that mostly people here have epilepsy or support people with epilepsy. Is that right? Okay. So I'm a psychiatrist, and I work with people like Dr. Lawn and Dr. Chan, and I see quite a lot of people with epilepsy from a psychiatrist's point of view. I also work in autism and intellectual disability, so there's often that crossover between all of those things. And today I'm going to talk a little bit about mood disorders, particularly depression in epilepsy. I am going to talk about suicide as well, if anyone feels sensitive about that. And I'll leave plenty of time for questions, because I think there are probably some aspects of my talk that are a little bit technical, but I'll try to put everything into plain language. So I want to start just by quickly revisiting the classification of seizures. Have you had something on this already today? No? Okay. So probably, yes. This one? I think I've got two, so yeah, sure. One of the epilepsy specialists might speak to you about this classification, and some of you may know whether you've got generalised epilepsy or focal epilepsy. And the reason I'm bringing it up is because psychiatrists do sometimes see focal epilepsies or see those presenting because they're not associated with those sort of tonic-clonic generalised seizures, and they can be quite subtle. And psychiatrists also have a long history of involvement in epilepsy, and in fact, it was a psychiatrist who developed EEG, Hans Berger, and this is a picture of the first EEG. They're a little bit more comfortable these days. And the other thing I like to remind the neurologists about is that it wasn't psychiatrists who used to do lobotomies, it was neurologists. Neurosurgeons, sorry. That's nasty there. So, no, that's true. So, one of the reasons that seizures sometimes present to psychiatrists, and I talk to psychiatrists about epilepsy and seizures, is because there are some of these unusual focal seizures that may not be so obvious, and the ones that are particularly of interest are seizures that begin with automatisms, because they can look a lot like the repetitive behaviours of autism, for instance, or intellectual disability. And I was hoping to show a clip of one, but unfortunately it's been taken down from YouTube. I'm not sure why, but it had it sort of had one of these very stereotypical behavioural episodes in a young man who sort of did windmills with his arms. And you wouldn't think much of it really if you weren't told that it was a frontal lobe seizure. And seizures can also present with things like episodes of sudden emotionality that's sort of not, so laughing or crying that's out of context. And sometimes seizures also involve presentations with sensory symptoms. So some of these things can look like panic attacks or like dissociative episodes where people feel disconnected from themselves, like they're like the world isn't real, or they're not real. And so sometimes these things do present to psychiatrists. But what mostly the role of a psychiatrist is in epilepsy and seizure disorders is managing problems with mental health that are associated with epilepsy. And so that's what I'm going to cover for a moment, because it's more common than you might imagine, and there's a very complex relationship between mood and epilepsy. So there have been a couple of very large sort of population size studies done in Europe on how common mood disorders and other psychiatric problems are in people with epilepsy. And what you can see here is that just for major depression, over the course of any given person's life, there's about a 10% chance, or about 10% of people will have depression at some point in their lives. But in epilepsy, it's almost twice as much, and there's quite a large range as well. So, it might even be as high as 25%, which is quite high. If you take any depressive disorder into account, so that's sort of a technical definition, but not everything counts as major depression. There are sort of more smaller depressions, if you like dysthymia is a diagnosis we sometimes make. You add a few percent again. So if you admit kind of more mild depression, it's higher again. And then for any mood disorder, that really takes into account bipolar disorder as well. And that's making, quite a substantial contribution to the rate of mood disorders in epilepsy. And so, on the broadest definition, maybe about a third of people with epilepsy will experience a mood disorder at some point. Now, what's also, somewhat alarming and worth being aware of is that suicide risk is also increased in people who have epilepsy compared to people who who don't have a diagnosis of a mental health problem, or who just have a mental health diagnosis. So if you have both epilepsy and a mood disorder, you're about 3 times as likely to die from suicide as someone who does not have epilepsy. So that's significant. And there are some particular risk periods. So in the 6 months shortly after someone is diagnosed, their risk is 5 times higher. So if they've got depression and then they receive a diagnosis of epilepsy, then that risk is higher by 5 times than the general population. But one thing to put this into perspective is that suicide is very rare. So even when we talk about 5 times the rate, we're still talking about a very small number, well below 1%. If you have any psychiatric condition at all, so that even includes things like anxiety, the risk goes up again to 13 times normal, and it can get as high as 30 times normal if sort of the stars align in a unfortunate manner, and you've both had you have a major mental illness and you've recently been diagnosed. So just to reiterate, to put this into perspective, these look like big numbers, and they are very significantly increased risks, but they're increased risks of a very small problem. Does that make sense? But it's worth being aware of. Now, what's sort of intriguing about epilepsy and mood disorders is that you might intuitively think that mood disorders are more common in epilepsy because you've got more to deal with. You have more difficulties or disability or negative social experiences, but it's not quite that simple. Because for the first point to make is that the association runs both ways. So if you have epilepsy, you're more likely to develop depression than someone who doesn't. But surprisingly, if you have depression, you're also a little bit more likely to develop epilepsy, which is weird. And the more, this is maybe not so surprising, the more seizures you have, the greater your risk of developing depression. The more resistant your seizures are to treatment, the greater the likelihood that you'll develop depression. But here's a really interesting statistic. For people who haven't been diagnosed with epilepsy yet and might not have had a seizure yet, there's still an increased risk of suicide before diagnosis, which is also and it speaks to the fact that there's an unusual relationship between the two conditions. So there are a few ideas about why depression might be more common in people with epilepsy, and the obvious thing is are these sort of social factors, like its impact on participation in school and employment and leisure. There's probably some shared risk with other things. So if you have epilepsy, you're perhaps more likely to also have another developmental problem like autism or intellectual disability, and so and then those things are independently associated with more depression as well. It's not a big consideration, but it's something that people always wonder about, is whether anticonvulsants are implicated in depression. There's some, there are some anticonvulsants that are a little bit more highly associated with depression than others. But again, it's a complex relationship. I'm going to talk a bit more about that in a moment. And there's a lot that we don't know about why the two conditions are related. So psychiatrists also use anticonvulsant medications in psychiatric practice, not for epilepsy, not for seizures, but for mood disorders. So sodium valproate, lamotrigine and carbamazepine are all considered to be mood stabilising as well as anticonvulsant. So if you have bipolar disorder, you may be on one of these medications even if you don't have epilepsy. And sometimes if you have severe major depression, you may be on one of these agents as well. And it might be that if you stop those agents, that you've got a mood disorder, you're more likely to have another episode of depression or mania, for instance. Some of the anticonvulsants seem to affect people's behaviour in a negative way sometimes, and that happens more commonly for some than others. And so that can be things like agitation, or occasionally things like suicidal thinking. It's not overly common, but it's something that occurs occasionally and that neurologists take into account. And you can also get interactions. So there are some anticonvulsants that interact quite a lot with other medications, and so that can have an impact on whether your antidepressant treatment is effective or not, or so it might make your antidepressant treatment relatively weaker, or it might make your antidepressant much stronger and not tolerable. Does that make sense? And then the other question that everyone has is, if you have epilepsy, is it safe to be on an antidepressant or a psychiatric medication? And in my training, and mostly in psychiatry, psychiatrists worry about whether antidepressants might raise or lower, particularly lower, seizure threshold and make it more likely that you'll have a seizure. But generally, the effect of that is less evident in clinical practice than it is predicted by physiology, if that makes sense. So in physiological studies, there are some psychiatric medications that lower seizure threshold, but in clinical populations, not so many people actually experience increased seizures. So it's something that, in clinical medicine, what we're most interested in is what actually happens to patients rather than what do things look like in the model or in the lab. There is a small increased risk of seizures for all antidepressants. Some are worse than others. So there's one called bupropion, which is also called Zyban. It's a quit smoking drug that is also a very good antidepressant, but it's certainly implicated in people having more seizures if they have epilepsy, and generally it's not prescribed to people with epilepsy. There are some exceptions, mostly in North America, but it would be very rare for that to be prescribed in Australia. Sertraline and venlafaxine are two antidepressants that have been studied the most. So the trade names of those are Zoloft and Effexor. And those are the ones that the epilepsy experts recommend as the best choice to start with because there's the most data. And then there are some really strong antidepressants that are really only going to be considered by specialist psychiatrists in consultation with neurologists. So monoamine oxidase inhibitors, don't worry about trying to remember that word. They're used very rarely, although they're actually not a bad choice for epilepsy. And tricyclics, which you might have heard of. So sometimes GPs prescribe a tricyclic called Endep to help people sleep. It's an antidepressant, and at higher doses, it might be a little bit of a problem. The other class of medication that may be relevant is antipsychotic medication, and that's because it gets prescribed for mood disorders like bipolar disorder. We do have patients who are on both an antipsychotic and for their mood disorder and anti-epileptics for epilepsy. Clozapine, which is used for treatment-resistant schizophrenia, is really the one of most concern, and that's really quite an uncommon, a relatively uncommon condition, certainly relative to epilepsy. But the other thing I wanted to say about it was, I had it in mind a moment ago and it slipped. Sorry? Yeah. It might come back to me in a moment. Now, I did put a little slide up here just to show that clozapine does affect the EEG, and so it slows down the EEG a bit. So it definitely has some impact, and it can cause changes that look a little bit seizure-like. But that's a very specialised topic. I probably shouldn't have left it in, but I gave this talk to some other people recently. But really, I've got just a few key take-home messages. The first is that although there are some concerns about using psychiatric medications to treat mood disorders in epilepsy, it's actually very important that they are treated because they're common. They're associated with really awful outcomes sometimes, like suicide. And depression in itself also creates a lot of disability. And so often when I talk to neurologists about, balancing the risk of using a medication that might improve mood, but theoretically lower seizure threshold or make a seizure more likely, it's often the case that the priority is to treat severe depression rather than worry about a theoretical or potential seizure. The other point I want to make is that medicines aren't the only things that are used to treat depression. So psychotherapy, talking therapies, in people who don't have epilepsy, they're just as effective as medications. But for most people find medication more convenient. And the combination of the two is better than either one by itself. So even if you want to avoid antidepressants in epilepsy, you've still got psychotherapy to use. What evidence exists shows that antidepressant medications work just as well in people with epilepsy as they do in people without, but there aren't that many big trials that have looked at it directly. And the worries about worsening seizure control are generally disproportionate to both the theoretical risk and also what actually happens clinically. The last thing just to mention in passing is I don't know how many of you are aware that we still use electroconvulsive therapy for very severe depression, like psychotic depression or the kind of depression where people stop eating and drinking and they'll die of self-neglect if they're not treated. And it can still be used in patients with epilepsy. It's just a little bit more complicated because Someone with epilepsy is going to be on medications generally that prevent them from having seizures, and the mechanism of action of ECT is that it causes seizures in a controlled setting in a hospital. So that's just a little point to keep in the back of your mind if you're someone who has very severe depression, or you're looking after someone with very severe depression. And then this is the last slide, that this is sort of what I encourage psychiatrists to do, because sometimes they're a little inexperienced at managing depression in people who have epilepsy. And so they will generally consider whether a psychiatric presentation could be related to an anticonvulsant. And like I said, some of them are a bit more likely to have behavioural effects than others. And then they would liaise with the neurologist if they thought that was an issue. And you know, sometimes it isn't. Sometimes it's just a concern a psychiatrist might have, but it's really not felt to be likely on discussion with the neurologist. They'll generally consider the potential for interactions between anticonvulsants and psychiatric medications. And again, there are some combinations that are a bit more likely to interact. It's really important that psychiatrists and neurologists work together when someone has both kinds of problems. And it's very rewarding for both of us, I think, the psychiatrist and the neurologist, to do that, and it's better for patients as well. And everyone, you know, in Western Australia is pretty good at doing that. And I know that my own psychiatry colleagues will often get in touch with the epilepsy specialists to discuss treatment when they're concerned. So that's all I brought today, and we've got some time, I think, for questions, which I thought might be the most interesting part.